Next, we're going to hear from my friend Mike Snyder. And Mike practices at the well-known Cincinnati Eye Institute and has an academic appointment at the University of Cincinnati. He's published over 100 articles and book chapters, and Mike's main interest is cataract surgery and complex anterior segment reconstruction. I have a referral anterior segment practice, and when I not only don't know the question, I don't know the answer, I send the patients to Mike. He's also interested in the ergonomics of ophthalmology, and he's going to speak to us today about integrating the Lenstar into both the clinic and the operating room. Take it away, Mike.
Warren, thanks very much. It's really a pleasure to be here with all of you today, and thank you for making the long trek down the hall. I know that we all got our steps in today on the way over here. I do want to acknowledge that I do consult for Haag-Streit. So I'm going to talk about different pearls, and we're going to break them up into different areas. Now, Frank just mentioned a number of the really good pearls within the testing zone, so I'm not going to spend a bunch of time with that. But in addition to what he's already mentioned about being able to delete a data point, unlike many other machines, when the data is collected, in many of the other machines that we have out there, if you want to delete a data point, you have to delete all of the associated data points as well. So if there is a click that captured an axial length, a keratometry, a white to white, and all of the lens thickness and such, if you want to delete one of those with some of the other machines, you have to delete all of the ones that were done with that same click, whereas with the Lenstar you can actually delete one at a time. If you've got a difficult patient perhaps with nystagmus or unusual anatomy and they're difficult to capture, that can be a real challenge. So one of the pearls for the testing zone is that all of the data is actually captured simultaneously with the same click of the button. And that's very important. We're going to get back to why that's important a little bit later. We always like to mention in the testing zone, my team always asks the patient, have you removed your contact lenses prior to doing this study? Ask me why we ask that, right? Because many years ago, about 10, 15 years ago, we actually had a patient who had the front of their contact lens measured, and their refractive error was exactly the power of their contact lens. So there's just a little pearl that's not specific to Lenstar, but it's a really good thing to have in mind. We always have our techs ask the patients, have you had refractive surgery? And sometimes we say refractive correction because sometimes people don't know that it was actually surgery or don't think so. There's a couple pearls now as we move to the exam lane. Frank mentioned how important the tear film is, and I'm just going to talk about a little bit of pragmatics about what I actually do personally in the exam room. I look at two pieces of data. I look at the placido ring first, and if the placido ring looks nice and even, and all of the Myers look beautiful, then I look at the computed topography component off the T-cone, which is giving me the mathematical derivation of what those rings tell me. But I always look at the tear film first on the placido rings. For example, in this patient, there's not really great placido rings, and so looking at the mathematical derivation, it really isn't so important. This is a tear film patient, and as Frank mentioned, we just need to make sure that we maximize their tear film first, and then deal with the other issues later. Then, in this patient, I look at the right-hand side, I see that the Myers look really good, and I see that there has some astigmatism, but the astigmatism is fairly regular. So I'm looking at what is the regularity of the astigmatism once I've recognized a good tear film. Here's another patient, higher amount of astigmatism with a high degree of regularity. Now I know you guys are going to look at that one little spot in the inferotemporal area and you say, oh, well, there's a little tiny spot there. That one really is not particularly relevant, and as we look at the mathematical derivation, that single data point gets expunged. Then we look at this and we say, well, that is not quite normal. I'm sure all of you look at this and you say, there's some irregularity there. This is a hyperopic ablation that was off-center and an unusually oblate cornea, prolate cornea. And so we expect that we might have issues. And if this patient didn't have refractive surgery, we ask them which one they actually had because they did. And then we've got one that looks like this. And we say, boy, the Myers look pretty good in most areas. There's a really high amount of astigmatism. So is there anything else we need to think about? Well, there is irregularity. We recognize that. The most irregular component is up there. And as it turns out, this could be mapped out fingerprint dystrophy, so we look at that and correlate our exam to it. Or it could be trauma-related. It turns out it was trauma-related in this instance. So then when we look a little bit further into the hard data from the sheet that comes out, and this is all things that I'm doing in the exam room with the patient in front of me, I like to look first at the axial length. Is this a normal axial length? Is it an extra long eye? Is it a short eye? Is it an average eye? This one turns out to be an average eye. That's all good. Is there any difference between the two eyes? Is this an anisometropic patient, and is that important for us to know? Is it amblyopic, perhaps? If it's an anisometropic hyperope, we got to think about that, right? This is all information I look at before my exam. What else do we think about in the examining room? Well, how about the corneal thickness? Actually, the Lenstar is capturing your corneal thickness, so please use that data. This patient's corneas are slightly thickened. And so if you have a patient who's got thicker corneas than average, you might not be measuring their IOP properly. And so it's important to think about that. Are we overestimating or underestimating their IOP? When we look at the optic nerve, or should we be more or less suspicious than we otherwise would be? It's all information that we have at our fingertips with the Lenstar. And then I look at the anterior chamber aqueous depth. And in fact, my team members look at that before they dilate the patients as well, just so that we don't inadvertently dilate somebody who has a shallower or smaller anterior chamber, because we really hate to induce anterior chamber issues with closure. So our techs are looking at this all the time, so do I. Well, how about the difference between the depth between the two eyes? Is there a loose lens, perhaps, that we didn't recognize as one anterior chamber deeper than the other in an otherwise same length eye? And when we interpret the Barrett-Toric calculator's magnitude, there's a couple little tips that I want to pass along to you, and they're very useful for me. First, I like to look at this part. Now, that is actually the predicted amount that a given implant lens with toricity will correct. In this instance, it's saying that a 1.5 diopters of toricity will correct roughly a diopter of astigmatism. But also look at the area down here. That's what the computer is telling you will be left over afterwards. So in the right eye of this particular patient, we've got roughly 1.4 diopters of astigmatism, of which 1.0 would be corrected and 0.3 would be left over, slightly less in the left eye. Now, this becomes important because we need to look at the axis of those two measures. Here you can tell that the axis of the steep astigmatism is the same as the axis of what's left over. Now, here's where we need to think about it in detail. When we look at this in detail, not all eyes are the same. So we see on the right eye, the axis of astigmatism is the same as what's left over, and the other eye, you see that it's flipped, albeit not by a lot. That's important to know because you may not want to flip the axis, and sometimes those magnitudes can be a little bit higher. There's a couple other things I want to call your attention to, and these are from mistakes that I have made. Yes, indeed. So if we look at this, this is what I like to call bewaring of the teens and the centurions, okay? So look at this. We've got an axis of 100 degrees, and there's a little bit left over at 10 degrees. 110 look pretty similar. That's a flip, right? So there's 100 degrees and a 10 degrees. That's a 90-degree flip. And though there's not much left over, you could see how, especially with the degree marker, you might inadvertently write down 10 instead of 100 or 100 instead of 10. Do not be confused. Always be alert to look at the steep axis that's in the center. Ask me how I know. Also beware of the teens, because all of the teens are also going to look similar. 1.6 with a degree mark looks a lot like 1.06. Don't confuse those. When we pick the power, there's a lot of really important things to discuss. However, I think I'm going to leave that to Dr. Sandoval and to Dr. Hill to discuss, and I'm going to skip right over that part. And now we're going to talk about Lenstar pearls in the operating room. Yes, the operating room, you say? Indeed, the operating room. Why would we need the Lenstar in the operating room? I wonder, okay? Well, remember that astigmatism we were talking about before? Well, when we get to the toric axis, we need to identify that toric axis. And yes, indeed, there are still people, lots of people in the world who are still using the purple magic marker to identify the axis. And this just doesn't look that perfect to me. And so, well, there's other people who have come up with solutions, but using the purple magic marker, it's not that sophisticated and it doesn't work that well. And sometimes I'm betting that it can bite you in the pajamas. So I would recommend against that. There's much better techniques, and the Lenstar is a better technique. Now, for years, about 10 years ago, I started looking at landmarks on the cornea and landmarks on the vessels that are perforating. I drew little pictures on my plan, and that worked okay. And then Bob Osher created a system where we're actually able to pick those out with photography with the Osher toric alignment system that Haag-Streit supported, and that was back in, I think it was 2009, so we're almost 10 years out from that. But there's a couple important things we need to think about. It's defying gravity. These two topographies are the same eye. Patient was tilting their head slightly to the right in one and tilting their head slightly to the left in the other. So what we really want to know is not what the astigmatism is relative to gravity. We need to know what the astigmatism is and what the landmarks are relative to when the keratometry was performed. Remember we talked about simultaneity before? Again, bubble marker works great, but it's not relative to where it was measured relative to gravity, right? So the simultaneity of the image and keratometry capture are super important. Remember when I talked about that one click where Lenstar captures everything at the same time? Well, part of what it's capturing is an image of the anterior segment. And so when that keratometry is captured, the image of the anterior segment is captured at the same time. I don't care whether the patient had their head on their ear, as long as the keratometry and the picture are captured at the same moment. Then when I use my reference marks, I know I'm going to be getting it right. And this information can now be transferred ergonomically directly to the operating room. This is my operating room, and you see the beautiful Haag-Streit microscope there, which has the platform on it that I can run the Lenstar software directly on that platform and get a great view where I can just glance up at that screen and have the beautiful picture that I can align my toric alignment with, right? So that's great. Now, some of you may not be as lucky as I to have the wonderful Haag-Streit microscope available. Haag has actually made the platform available so that the Lenstar software can be run on Citrix. And this image is actually showing the Lenstar software run on Citrix, showing up on an iPad on a flexible device, which I can glance up at, even with a different kind of microscope and OR system. And when we look at how that is, you can see on the just to the left of the base of the scope, there's just an articulating arm holding up that iPad, and I can put it wherever I want to look at it very ergonomically. Now, ergonomics are important, and I want to make a note of that. Notice that we've also, Haag has designed this ergonomic chair that supports the low back. Incidence of back disease among ophthalmologists is about 55% diagnosed, so better seating is really important. And also, I think that we need to make sure for better foot pedal position. So Lenstar has your patients covered, and Haag-Streit's got your back. So just for quick conclusions, I'd like to say that the Lenstar is easy to incorporate into the workflow and into the clinic. There's lots of wonderful pearls for us to enjoy. The Lenstar improves the biometry. It improves our accuracy with our outcomes, allows better execution in the operating room, and improves the patient's outcomes. And the Lenstar helps us really from check-in all the way through post-op, and makes the workflow easier. Thanks so much. It's a pleasure to be here today.
Thank you, Mike. Thank you.